You can easily save a life if you know the correct approach to azotemia. First of all, what's azotemia? Azotemia means there is decreased GFR with increased serum creatinine. Now, how to approach it? First of all, rule out hydronephrosis. That may be due to any obstructive pathology or a urological cause. Go for USG analysis and urine analysis. After ruling out hydronephrosis, now you go for checking the size, shape and ecotexture of the kidneys along with further urinalysis. If the kidneys are small and shrunken with bland sediment, lost CMD, isostenuria and a less than 3.5 gram proteinuria for 24 hours, it clearly indicates CKD. Just go for symptomatic management to delay the progression, and if it's end stage, you go for hemodialysis. But if the USG shows that the size, shape and ecotexture of the kidney is normal, then it's a case of acute kidney injury, that's acute renal failure, and you go for urine analysis. If it is normal but with oliguria, you go for urine electrolytes. If the fractional excretion of sodium is less than 1% and the urine osmolarity is more than 500 milliosmol per liter, then it's a case of pre-renal azotemia. The causes are volume contraction, vasoconstriction, drugs, sepsis, shock, impaired autoregulation or cardiac failure. But if the fractional excretion of sodium is more than 1% and the urine osmolarity is less than 350 milliosmoles per liter, then it's a case of acute tubular necrosis. But now, with normal size, shape and ecotexture of the kidney, you have an abnormal urine analysis. Then you go for the details. If there's bacteria, it's pyelonephritis. If it's WBCs, casts and eosinophils, it's interstitial nephritis. If it's RBCs, that's red blood cells, it's either renovascular, that is renal venous or arterial occlusion, and you go for an angiogram. If there's RBC casts along with proteinuria, then you go for biopsy. You need to rule out vasculitis, glomerulonephritis, immune complex mediated diseases or anti-glomerular basement membrane diseases. Now, if there is muddy brown casts with amorphous brown sediments, then you go again for the urine electrolyte chain. Thanks.